A Ference. While he goes to the stage, as an introduction, there's a general tendency to believe that the lower the blood pressure is and the lower your LDL is, the greater the chance to reach eternal life. I've always been a bit doubting about that, but the next presentation will show you that it's actually true.
Well, I don't know about that, but
Sorry.
thank you, Mr. Chairman, and good morning, everybody. So these are my disclosures. By way of background, we know that observational studies tell us that persons who are able to maintain ideal risk factor profiles throughout the whole of their lifetime have very low lifetime risks of cardiovascular disease. However, fewer than 5% of people are able to maintain those ideal levels. By contrast, Mendelian randomization studies tell us that both LDL cholesterol and systolic blood pressure have both causal and cumulative effects on the risk of cardiovascular disease. That would suggest that a very simplified prevention strategy that focuses on maintaining low levels of both LDL cholesterol and systolic blood pressure would be a potentially effective strategy for preventing cardiovascular disease. However, the causal effect of combined exposure to both lower LDL and lower systolic blood pressure is unknown. And in fact, the recent landmark HOPE-3 trial reported that persons who were treated with the combination of a lipid-lowering therapy plus a blood pressure-lowering therapy did not reduce the risk of cardiovascular events significantly greater than lipid-lowering therapy alone. That has caused some to question the synergy between LDL and systolic blood pressure and the risk of cardiovascular events, particularly among persons without hypertension. So the objective of our study really was to assess the causal effect of combined exposure to lower LDL and lower systolic blood pressure. And as a secondary objective, we sought to measure the potential clinical impact of a simplified strategy that promotes long-term exposure to 1 millimole lower LDL and 10 milliliters lower systolic blood pressure. Now, the only way to directly estimate the causal effect of combined exposure to lower LDL and lower systolic blood pressure is with either a 2x2 factorial randomized trial, or in this case, a 2x2 factorial Mendelian randomization study. So we constructed genetic LDL scores and genetic systolic blood pressure scores to naturally randomize 100,000 persons to either lower LDL cholesterol alone, lower systolic blood pressure alone, or both, using a factorial Mendelian randomization study design. Now, it's important to note here that the study has nothing to do with genetics. Instead, this study was specifically designed to evaluate the effect of random allocation to lower LDL, lower blood pressure, or both on the risk of cardiovascular disease. The genetic polymorphisms were merely convenient instruments that allowed us to naturally randomize people into various groups. What we found is that a total of 14,000 major vascular events, defined as the composite of cardiovascular death, MI, stroke, or revascularization, occurred in up to 32 years of follow-up. And what we found principally was that the combined effect of lower LDL and lower systolic blood pressure had an independent, multiplicative, and cumulative effects on the risk of cardiovascular disease. The effect of combined exposure to lower LDL and lower systolic blood pressure was significantly greater than the effect of lower blood pressure alone, with a p-value of 10 to the minus 14, and significantly greater than the effect of lower blood pressure alone, with a p-value of 10 to the minus 23. And in fact, because the effect of lower blood pressure and lower cholesterol is both multiplicative and cumulative over time, the effect of a combined exposure to 1 millimole lower LDL and 10 millimeters lower systolic blood pressure was associated with an 86.1% lower risk of cardiovascular disease. And in fact, this same combined 1 millimole lower LDL and 10 millimeters lower systolic blood pressure was associated with a consistent 80 to 90% reduction in the risk of all of the composite cardiovascular events, including the individual components of the composite events, and with an 84% reduction in CHD mortality. Now, that large reduction in CHD mortality translated into a smaller but still robust 36% reduction in all-cause mortality. And in addition, the effect was similar among men and women, smokers and non-smokers, diabetics and non-diabetics, and importantly, among persons with LDL cholesterols above and below 3.4 and systolic blood pressures above and below 120, suggesting that the benefit of combined exposure to lower LDL and lower systolic blood pressure would extend to persons who have apparently normal blood pressure and cholesterol levels. So we conclude from this that LDL cholesterol and systolic blood pressure have independent, multiplicative, and cumulative effects on the risk of cardiovascular disease. And because the effects are multiplicative and cumulative, long-term exposure to even modestly lower combinations of LDL and systolic blood pressure has the potential to dramatically reduce the lifetime risk of cardiovascular events, even among persons with normal blood pressure and cholesterol. So importantly, our study confirms that cardiovascular events are largely preventable, and it suggests that the prevention of cardiovascular disease can be substantially improved and is substantially simplified by simply designing prevention strategies that focus on promoting long-term exposure to lower LDL and lower blood pressure beginning in early adulthood. Thank you.
Thank you very much. This exciting presentation complements to it. 90% reduction rate. Oof, it rocks me off my chair. There should be questions in the hall. Yes, please. Peggy.
Hi, I'm Peggy Peck with MedPage Today. So this is very interesting, but I'm just trying to understand. It was a year ago that at the ESC meeting that HOPE-3 was presented, I think, and I believe I'm right about that.
It was ACC last March.
Okay, I apologize. But at any rate, at that time. It was sort of a shock that the blood pressure lowering did not seem to show benefit, and that the benefit seen was attributed to the LDL lowering. And so now, should we just set that aside?
No, no, sorry.
So, because I'm trying to think of what is the advice to the clinician? How can this be used now, today, in managing patients?
Right, so if I may, I'd like to address the first question first with regard to HOPE. So I think HOPE was an extraordinarily important study. It did show that lowering systolic blood pressure by 6 millimeters of mercury reduced events by about 7%. It just wasn't statistically significant. In addition to that, the combined intervention arm reduced risk by about 29%, which was more than the 24% reduction with LDL lowering alone, but once again, it didn't reach statistical significance. Indeed, if one multiplies the effect of lower LDL by the effect of lower systolic blood pressure in the HOPE trial, in the two arms of the HOPE trial, one gets exactly the effect one sees in the combined treatment arm. So we would suggest that our data are perfectly consistent with the HOPE trial. It's just that the magnitude of the blood pressure lowering may not have been large enough, and the follow-up may not have been long enough in order to translate into a statistically significant effect. And these data would suggest if one does that, lowers blood pressure and cholesterol over the long term, because the effects are cumulative, there's likely to translate into much larger reductions in the risk of cardiovascular events.
I had meant to mention this. So you're talking about 10 millimeters of mercury, and that seems to me a fairly significant reduction in blood pressure, and sort of in the United States, trying to control blood pressure or get people to target whatever you think that target should be has been controversial, and it's been difficult to attain that. So it seems to me that this could be a tough goal for clinicians to get their patients to that goal.
I think that's right. But there are two issues. Data we don't show here, but we will show in the main presentation, is that long-term exposure to lower LDL also slows the rate of rise in systolic blood pressure with age. So that's suggesting that if one begins early to manage blood pressure, that can lead to substantially lower increases in blood pressure over time, which dramatically reduces the risk of developing hypertension.
But I would hesitate to use these results as an incentive to even give patients more drugs. As you know, physical activity, food habits, smoking, they all interfere with blood pressure levels and with LDL. So I think my take-home message would rather be make your program, your rehabilitation program, even more effective. Of course, drugs might be needed, but don't take this as just an incentive to give patients even more drugs. The other part is equally important.
Right, I agree with that. I think that it's important that this isn't at all about long-term treatment with medications. In fact, our study can evaluate that, but rather it focuses the emphasis on monitoring and maintaining lower blood pressure and cholesterol, beginning much earlier than is currently recommended. It also guides emerging countries who have an explosion of risk factors about where to allocate resource most effectively in order to reduce risk of cardio events most effectively. I happen to have a license to practice medicine in China, where there is an extraordinarily high burden of cardiovascular risk factors. And treating those, focusing in a parsimonious way on those that are most likely to reduce risk, can inform public health policy. It also has the opportunity to translate how we use continuous biometric monitoring data. So certainly as we enter into the era of biometric monitoring and big data, we can begin to use that information about how dietary components or lifestyle choices or activities specifically affect our blood pressure and cholesterol. And then we can use that data to choose those components of the diet or activities or lifestyle factors that maintain our blood pressure and cholesterol as low as possible for as long as possible as a strategy to reduce our lifetime risk of cardiovascular disease.
Yes.
Bruce Jansen, Cardiology News. I've heard experienced cardiologists and researchers say that a therapeutic effect of 25 to 40% is dramatic, say ACE inhibitors for heart failure, and that it becomes a less plausible result as you get into the miraculous range. So
I would agree with that. Okay. So, but I would suggest, however, that what they're referring to is the expected benefit one can achieve in a short-term trial with very short-term follow-up. These data are important because they suggest that both blood pressure and cholesterol have not only causal but cumulative effects over time, which means that the effect of a 1 millimole lower LDL, for example, in a trial may reduce events by 20%, but over the long term they reduce events by 50% because of that cumulative effect. Blood pressure has a similarly causal and cumulative effect, and when present together they have multiplicative and cumulative effects, which leads to these outsized reductions in the risk of cardiovascular disease.
A question in the backyard there.
Nicolas Donchin, Cordiam. Did you look at non-cardiovascular mortality or cancer mortality to be certain that your randomization process did not simply select populations at higher versus lower overall risk?
We did. So there was no difference in non-cardiovascular mortality. And in addition to that, the smaller reduction in overall mortality was simply a function of the fact that CHD mortality was a lesser event, or less frequent event than all-cause mortality.
Good. As more and more patients are surviving myocardial infarction at the moment, I think this finding is important because we are not getting fewer cardiac patients. In clinical practice, we get more and more that survive. So a 90% reduction would put a lot of cardiologists out of job. Am I right?
Well, the 90% reduction implies the potential maximum benefit that one can achieve over the long term. And the shorter one begins to intervene, the less potential magnitude of the benefit one can achieve. So after an event, that would be a slightly different population because they would have less long-term exposure to either of those risk factors.
Great presentation. Thank you.
Thank you.
We go over to the next